Good afternoon, everyone. First of all, I would thank Dr. Amit for inviting me to deliver this talk. And the topic for today is how to ensure better yield of biopsy tissue sample. So, as we know, why do we require a biopsy? First, it is for proving the malignancy. Second is for staging, and third is for planning therapy. And today, there are various types of biopsies which are available, be it surgical, be it endobronchial, that is EBUS or bronchoscopic guided, and third is percutaneous and image guided. And why are we talking about the image guided one? Because it is more precise. You can target metabolically active area with more precision. So if we see here, the metabolically active area is on the medial portion close to the trachea, and we can target it easily via CT scan guided. And there is less incidence of sampling errors. And fourth, it is safe procedure because you are seeing it under direct vision. And this is one which is close to the bronchus, and this is collapsed part of the lung. That is means we can target it much more easily. And what are the imaging modalities today that are available for doing biopsy? Either it would be EBUS guided, that is when you are doing endobronchial ultrasound guided, and we can take samples from that. When we do ultrasound guided, that is lymph node. When we see supraclavicular lymph node, that is when we can target it with ultrasound. Third is when we are doing for metastatic workup, and when we see lytic lesion in the C1 C2 junction, that is fluoroscopy guided biopsy, because we need real time imaging, because we are close to vital structures and the cord, and that is much better seen on the fluoroscopy. And CT fluoroscopy, obviously, for the primary as well as metastatic lung lesions. And fusion guided biopsy when we are looking at the PET CT scan, and we try to focus on the area which is PET avid and not the other part. So image guided has its own significance, and it has high accuracy, high specificity, and the specificity is as close to from it ranges from 60% to 97%, and high sensitivity around 82 to 92%, and has a high accuracy. So this is a paper which characterize all three, and it is meta-analysis. So FNAC obviously is inferior as compared to biopsy, and biopsy has much more better implication because the tissue is more. Coming on to the indications for the lung biopsy is that either we need to target a solitary pulmonary nodule or a mass or multiple nodules in case of malignancy to prove it's malignant or metastatic. And for NGS workup, for hilar masses, focal infiltrates, if we are suspecting infective etiology on if patient is on chemotherapy, that's where we need to target. In lung cancer, especially with the era of personalized therapy and immunohistochemistry plays an important role along with the subclassification and molecular markers. So, and the contraindication are pretty much limited, and most of them would be a non-cooperative patient, and when patient is having severe respiratory distress, positive pressure ventilation, extreme pulmonary hypertension, and severe interstitial lung disease. These are, mind you, related contraindication. Obviously biopsy can be done with a due risk, and patient needs to be counseled regarding those things. Needle biopsy, pre-procedure evaluation, what do we require before doing procedure would be coagulation parameters, which should be the INR should be less than 1.5. Platelets should be more than 50,000. If patient is on anticoagulants or antiplatelets, which needs to be stopped prior to doing procedure, and depends on what anticoagulants and antiplatelets are there. Patient needs to be informed regarding the complication, and there is less than 0.1% chance of death happening. So does every lesion require biopsy? And the answer to that is no. And this was a patient which was sent to us for doing biopsy of the lung lesion, and mind you, patient did not had a proper imaging prior to the procedure, and it was reported at lung mass. After doing doing a contrast CT, what do we find was the aneurysm which was arising from the internal mammillary artery, and this was coiled thereafter, and patient did not have any masses. Positioning of the patient is also equally important, because the chances of sampling error would be minimized if we are taking from the proper area, the location of the lesion, the size of the lesion. Obviously, if the bigger the lesion, better it is, because you can take more tissues from that location of the lesion. Obviously, this is a posteriorly located lesion, so the biopsy needs to be planned in a prone position. This is a small nodule which needs to be targeted from the anterior approach, and this is a supine approach. When the larger the lesion, the chances of having central necrosis is much more evident, and we need to target the periphery of the lesion. And in the liver, for targeting metastasis, we need to change the position from supine to oblique or intercostal approaches, which can be done. So prone position is preferable if we can target from anterior or posterior. And why prone? Because the posterior part of the ribs moves less than the anterior part. A patient does not see the needle, and which decreases the anxiety. And what do we need to target? We always need to target the cutoff wherever there is a bronchus cutoff sign, because that would be a solid mass as opposed to a collapse of the lung. So here it is a collapse of the lung, and this is a central lesion. We need to target the solid enhancing component, which is at the periphery. So this was a patient after treatment, and what do we see? There was a cystic area and some solid residual area which had newly come up after chemotherapy, and this is the central lesion, as I mentioned earlier. So this all were targeted, and which were proven to be malignancy. Many times what we see on the PET, which would be the PET avid area, which can be targeted with much better accuracy when we are doing PET guided biopsy. And this was again a solid nodule, and when we see at the lung images, this was a cystic area which can be targeted easily. And there are few caveats to that. What do we need to look at is the vessels, the fissures, and the intercostal neurovascular bundles. So this is the mammary which is located close to the sternum, and which we need to know while doing especially mediastinal lymph nodes biopsy. And when we are targeting lung biopsy, it has to be always from the superior surface of the rib rather than from inferior surface, because neurovascular and the vessels pass through the inferior. So here we can see the vessels which are passing through the inferior rib surface, and that's what we need to target. Fissures, probably the best thing is we need to avoid fissures wherever possible. Many times it would be difficult. The chances of pneumothorax increase is when we have traversed the fissure, and this is how the fissures are. And when we are targeting anterior part of the lesion, it has to be done from the anterior approach and not from traversing the fissures. That is much more important. So this is what I want to clarify. This was a small fissure. When the patient breathes in, that is the time the fissures move up and down, and then this is approach is not proper, and we need to plan properly. Another thing, when we are targeting a small nodule, it has to be always done in a free breathing movement. And if the nodule moves up, the trajectory, the needle trajectory needs to also go up, and it has to be in the opposite direction, because this goes up in the contralateral direction. So that's how we need to plan, and this is how the dynamic, if the lesion is moving down, the needle trajectory has to be changed, and it has to be done in a caudal direction. So many times when we are targeting a smaller nodule, that is the time we need to choose, instead of direct path, we need to choose oblique path, because the parenchyma available is much more as compared to the direct approach. And when many times there is emphysematous changes which can be avoided, and this can be done with the help of CT guided. These these all patient had severe emphysema, what we can see, we can avoid those emphysematous bullae or emphysematous changes. Coming on to the technique, which is much simple, low KV MA technique, limited slices, local anesthesia. Coaxial is always preferred to the non-coaxial because we can take multiple course, and obviously the needle length needs to be done, and the cutting edge of the needle, that is the coaxial system, should be where the lesion is. So this has to be in the center so that we can get multiple yields. When we are dealing with the surface, that is the time we can take multiple cores and we can adjust the throw and not beyond the lesion. Many times there would be ground glass haziness and things like that. So obviously, as I told earlier, depends on the gun type also. Automatic is preferable. Curved needle technique for lymph nodes can be done, and post biopsy scans needs to be done. Last EBUS is already been covered in the next stop, so I will just stop it. And the last slide, take home message. Biopsy is minimal invasive procedure. It is indispensable tool in diagnosing the thoracic lesion. It is very safe, it is effective with high degree of good accuracy. It is a daycare procedure and can be performed via trained and experienced physician. Always we need to target a solid enhancing area, PET avid area. We need to differentiate collapse of the lung from the mass while tissue sampling. Thank you.